Let me at the onset itself thank Jyoti sir for giving me an opportunity to chair the session, and also congratulate sir for taking such a great effort and pain to organize this event and making it a huge success. And the next section is basically about diabetic ketoacidosis. Now, as far as diabetes is concerned, we all know there are acute complications and chronic complications. And as far as acute complications are concerned, it is basically 3 in number. One is diabetic ketoacidosis, 2 is hyperosmolar hyperglycemic syndrome, and 3 is hypoglycemia. And the most important hyperglycemic emergencies are diabetic ketoacidosis and hyperosmolar hyperglycemic syndrome. And management of diabetic ketoacidosis, though we have been studying it right from our MBBS days, it's rather a very difficult job. And it is often a nightmare for all the postgraduates, house surgeons. And the presence of ketosis itself shows that the patient has a very low reserve of insulin in his body. And it is one of the most common presenting symptom of type 1 diabetes. And often in the late stages of type 2 diabetes, diabetic ketoacidosis is very common. And the management of diabetic ketoacidosis is also very difficult because we will have to meticulously look on several aspects like controlling the blood sugar, controlling the electrolytes, controlling the fluid imbalances. So this is a really big issue. And also in selected group of patients like chronic kidney disease, myocardial infarction, and patients who are having fluid overload, this is a real challenge. And to speak about this subject, we have a very eminent speaker. More than that, she is a very good teacher. She is a professor and head of the Department of Medicine, KMC, Manipal. I welcome Madam.
Good evening to all of you. I don't know how many of you can see me because I don't have much of a height. Can you see me? Yeah. Because I should not sound as if I am some voice from the nowhere. I think at the end of a long day, this topic is definitely a difficult topic, but knowing that all of you are physicians, all of you have been managing diabetic ketoacidosis for a long time, we will just focus on the main issues in diabetic ketoacidosis and not go, I'll just run over some of the details so that it's easier for all of us. The first thing is Dr. Jyoti wanted me to say something about the prevalence. Before that, the definition, we are all clear on this: hyperglycemia more than 250, ketosis, anion gap of more than 10, and acidosis of less than 7.3, and a bicarb of less than 18. And there are several studies on diabetic ketoacidosis prevalence, and as you can see from this slide, as the age increases, we get a lot of type 2. Now, though we know that type 1 is very important, we know that as practicing physicians, adult physicians, a lot of type 2 comes in as the age increases, especially with precipitating factors such as infection. Every time in our ICU, there is always one patient with type 2 diabetes with ketosis. This is a study from tertiary hospital in India showing that 80% of the patients are type 2. Most of them are on irregular treatment, hardly about 20% are on regular treatment. Everybody else is either irregular or skipped or not taken treatment at all or first time discovered. So it's still a very ongoing problem. The good news is that most patients with type 1 are all right, are still coming with ketosis, but type 2 young diabetics are becoming more mature and they are not coming with ketosis because they are more aware. The most important difference in the profile between type 1 and type 2 is that type 1 is unprovoked ketosis, type 2 is provoked ketosis, provoked by some precipitating factors such as infection, stress or stroke. There are several things. Every time we have a patient with a pneumonia with type 2, we have a ketosis sometimes. Myocardial infarctions, the cardiologists usually deal with it with a ketosis and they call us for a consultation. Abdominal emergencies can come in, intercurrent illness, omission, etc. Last week I discharged a patient with glucocorticoid-induced type 2 diabetes with ketosis. Patient was a diabetic and he had rheumatoid arthritis. Somebody put him on a steroid for pain control and then he came back with ketosis. So many of these drugs can precipitate and we should be well aware of that. Now, I just want to highlight a little less known problem. This is a patient of ours, 28-year-old female with DKA. In June, no precipitating factors, good BMI, family history was there, recovered with standard treatment, discharged and put on OHS, put back on OHS. So, what is this kind of condition? This is called atypical diabetes. This is a ketosis prone type 2 diabetes. These patients look like type 2. Their BMI is like type 2. Their reserve is good. They come with unprovoked ketosis. Unlike a type 2 which usually has a provoked ketosis, these patients come with unprovoked ketosis. So they are an in-between land between type 1 and type 2, and we have made a diagnosis in many of these patients. Apart from that, we have euglycemic ketoacidosis where the sugars are not very high, they are only less than 300. Can happen in pump patients. This is because there is more urine loss, and many of these patients do not require IV. We can get away with subcutaneous insulin. There is an article from the Lancet showing SGLT inhibition and euglycemic ketoacidosis. Now, because again the SGLT2 inhibitors are causing a lot of urine loss of the sugar may not be high, but they can have euglycemic ketoacidosis. So, what is the problem in DKA? It's a very simple thing. There is a deficiency of insulin in type 1 absolute, and in type 2 it is relative. And the most important thing to remember is that insulin is an anabolic hormone. If you remove the anabolic hormone, it will cause lipolysis, proteolysis and glycolysis, which is what we have read always. And we know these pathways, the lipolysis causing ketogenesis, ketoacidosis, and then this side, if you go only for hyperglycemia, you land up with HHS. So, why is there hyperglycemia? Because of insulin deficiency, and there is an increase in the counter-regulatory hormones. Why is there an osmotic diuresis? Because you lost the glucose and the ketones are pulling out the water in the urine. And why is there hyperosmolality? Because you retained your glucose, you lost your GFR. And this we all know, the free fatty acids, the acetyl-CoA, and then landing up with acetoacetate, beta-hydroxy butyric acid and acetone, the ketone bodies that we have always talked about. Now, what we will focus on is the management. So, when we see a patient with ketosis, what do we send? We send our biochemistry, sugars, renal function test, serum electrolytes, A1C, ABG for documenting the pH and the urine or serum ketones, and then we calculate the serum osmolality and do the anion gap, and looking for the focus of infection, we look for the urine, the blood picture, we consider blood culture and the chest x-ray. And based on these findings, we classify them as mild, moderate or severe. All of them, these charts are very easily available everywhere. This is only a degree of the hyperglycemia and the degree of the ketosis that we are talking about. We will focus on treatment. Now, the goals for therapy of treatment are 5. The first one is hemodynamic stability. The second one is electrolyte homeostasis. The third one is the correction of hyperglycemia and hyperosmolality. The fourth one is to find out the precipitating cause, and last is to avoid complications. The most important part of DKA treatments is fluids, and fluids. That's the first thing that we should all remember. The fluid is not just given for volume expansion, it's much beyond that. It decreases the counter-regulatory hormones, directly reduces the sugar, restores the osmolality, reperfuses the kidney, and these deficits are extracellular, intracellular and interstitial. All these can be replaced by fluids. What fluid do we administer? We give normal saline for extracellular dehydration. First 4 hours, it's very important, and then we can go on to half normal saline or 5% dextrose, which we'll talk about a little later. The 5% dextrose is for intracellular dehydration. Now, as common sense would dictate, if our type 2 diabetic patients come with ketoacidosis with renal or cardiac dysfunction, the cardiorenal syndromes, of course, we will not rush fluid into them and produce one pulmonary edema from nowhere. We will use discretion rather than guidelines. Now, the fluid replacement, this we all know, we give a lot of fluid, first 1 hour 1 liter, second hour 1 liter, and then we go on like that. And then we will use discretion, monitor the patient's JVP, basal Krebs, etc., hydration, and then use our fluid. But the first 2 liters must go without thinking. Insulin in the ICU is a very, very important topic. Insulin will go on half an hour after the fluids. That's the important thing. People rush and give insulin. It's not the first thing to give. The first thing to give is always the fluid. Why should we give it after fluid? Because if you don't give the fluid, it may precipitate hypotension and is less effective in the hyperosmolar state. And then the potassium. When the potassium is less than 3.3, insulin is actually contraindicated because it can push more potassium into the cell. You can get an arrhythmia because of that. So that's why the fluid goes in first, the insulin comes later. What route do we give? We can give IM, IV or subcutaneous. All of them will act, but the subcutaneous absorption may not be very good. That's why we go for IV. Which insulin? All insulin, any insulin can be given, but the analogs have shown good report except in severe cases, but the rapid acting insulin is probably the best. We all know this regimen, 10 units stat, nothing much has changed here, and 0.1 unit per kg per hour is what we give. What is the goal? 75 to 100 milligrams fall in the blood sugar per hour. If it doesn't fall, we just double the dose and see that we get this rate of fall. These things have not changed much, sorry. And we know that low dose insulin is okay and it is non-inferior to the standard dose, and this is applicable even for pediatrics. In the first 5 hours, we are not rushing to bring down the blood sugar. That's important. We do not go and produce hypoglycemia. When the sugar comes down, we can stop the insulin, but we restart it because I'll tell you why. And then we also maintain it around 140 to 180. Now, why did we say we will not stop the insulin? Because the insulin is given to treat the acidosis, not the hyperglycemia. The end point of treatment of DKA is the resolution of acidosis. So that should never be stopped before the acidosis is thing. If in case you have to still continue your insulin, you run a 5% dextrose drip on one side, keep your sugar going, come to the end point of treatment of acidosis. And these are the insulin infusions that we can see. These are all available in all textbooks. It goes with the sugar. But we remember that when we come down to 250, then we may still have to continue the insulin, in which case we'll have to give the dextrose on one arm. The pitfall is to allow the sugar to go to hypoglycemia. We never want a sugar less than 180, 140 like that. If you hit 80, then you get the counter-regulatory hormones, and this happens with many postgraduates that when we leave them on call, they hit 80 and then they come back with the ketosis, next day morning back to 500. Now this should not happen. When do we stop the insulin? We switch to subcutaneous insulin when the patient can eat, the sugars are less than 200, and most important, the acidosis has resolved. That is our endpoint. Now this transition between IV and subcutaneous is where most people go wrong, because if you do not give an overlap between the subcutaneous and the IV, you may come back with an hyperglycemia back again. Now, which ketone do we monitor? Beta-hydroxybutyric acid, butyrate is the predominant ketone, but the urine analysis is actually measuring the acetoacetate. So, initially, because we are measuring only acetoacetate, you may get falsely negative for ketone, and when you treat, the postgraduate comes and tells you, oh, the ketones are going up, the patient is actually better. This is because of better conversion, and that is why this happens. So, we must remember that we are measuring the acetoacetate and not this thing. The ketone meters are available for serum ketones, but most of us are using by urine ketone. So we must remember the conversion that happens, and falsely increased urine ketone, that will happen with better control. So I'll just skip this. Now, one very important thing of people practicing in the periphery who tell that whether we should do an ABG every time, for the pH, the VBG is good enough, the venous blood gas is good enough because the correlation is very high. So you can do a venous blood and look for the pH and monitor your acidosis. That's good enough. We do not need an ABG every time. Now, as the chairperson was telling, the electrolytes are very important. The potassium replacement is very important. Initially, the potassium is falsely high, and then it will all fall with treatment because the insulin will push the potassium into the cell, and so we will have to add potassium when we are treating with insulin to every liter. And this is how we monitor the potassium. So less than 3.5 we add 40, then 20, then 10, and more than 5.5 when the potassium is there, we do not give any potassium supplementation. Similarly with the sodium is also, because of dilutional hyponatremia, you may because of the high glucose, we may need a correction for the sodium, otherwise we will diagnose hyponatremia unnecessarily. The bicarb controversy, this is where a lot of things, literature has changed regarding the DKA, whether to give or not to give the bicarb. Why is acidosis bad? Because it depresses the myocardium, decreased response to catecholamines, more cardiac arrhythmia, so we have more hypotension. What are the benefits of giving bicarb? We are improving the myocardial performance. So this seems to be a very childlike logic that, okay, you have acidosis, give the bicarb, everything should be fine. But is it true? Is there a danger lurking under giving that bicarb? Now let's look at what is the problem. The bicarb will shift the oxygen dissociation curve to the left, so the oxygenation of the periphery will suffer. The hypokalemia that is already there will be exacerbated when you give your bicarb. The calculated deficits, the delta deficit that we calculate in the ABG may not really reflect what we call the delta is actually very unreliable in the presence of a DKA, and the correction of acidosis may cause a paradoxical CNS acidosis and depress the CNS. So because of all these things, we have points for and against bicarb therapy. So you can give bicarb, you think it aborts acidosis and shortens resolution, but the big point against is the potassium and the cerebral edema that accompanies the correction. And on the ground, it has been found that in 2013, this paper came out which showed no difference between giving bicarb and not giving bicarb in the time for discharge. So what are the guidelines now? We use clinical judgment. Less than 7 pH, we do give bicarb, and then we check the ABG later. But otherwise, just the correction of fluid, just the giving the insulin, all this will take care of the acidosis. Once a resolution of ketosis occurs, you do not need a bicarb. You do not need this controversy. A very good article from NEGM, February 2015, I think we should all read, regarding the acid-base controversies, where he highlights the point that we are all measuring concentrations. We are measuring per deciliter. We are not measuring contents. So that is the mistake that we make. This happens for the potassium, this happens for the sodium, this happens for the bicarb. This is an excellent article which talks about why we need not rush and give the bicarb. And this article argues that who should receive bicarb is not by a number, but those whose brain and kidney are not functioning well, because these are the organs which utilize the keto acids. So those in coma, those in renal failure, this is the people, this is the kind of population who should receive a bicarb. And we must remember there is a lag time between the administration of insulin and the decline in the bicarb, and we should not rush and give the bicarb. We can always wait. So for children, pH should be used as a determinant because cerebral edema is very common in children, more common in children than in adults. My pediatric colleagues always tell me that they give a little mannitol when there is cerebral edema, and in them, in children, the pH of 6.9, the bicarb and the hemodynamic instability are indications. So when do we say the DKA is resolved? We say it is resolved when the blood glucose is less than 200, the bicarb is less than 18, the pH is more than 7.3, the anion gap is closed, and the patient is able to eat a meal. We monitor the patients very regularly. We know the DKA chart. This is available with all our postgraduates. I don't think you can read it from where you are, but it is the vital signs, the glucose, the ketones, the electrolytes, all of them have to be monitored along with how much insulin you give and how much IV fluids you give. It has to be done very strictly, but it's a life-saving thing. So we must put our effort, and one postgraduate is always sitting next to a patient with DKA. It's a very satisfying thing to save a patient from DKA, but it requires care. Cerebral edema, as we said, most commonly in children, and this is again a final chart on what we should do in the first 60 minutes, 6 hours and 12 hours. It's only a summary that you can access. The most important thing is the prevention. Don't miss insulin. Sickness schedules must be explained to type 1 patients, and type 2 patients, elderly with infection, look for a ketosis. Recognition of the problem is important. The prognosis depends upon hypotension and acidosis. This is our paper which we presented in ADA 2013. These are the only 2 things that affects prognosis in a DKA. So future research for those of the young people who are sitting here, the bicarbonate in DKA is still unresolved. The priming dose of insulin is still not fixed. Pro-inflammatory markers in DKA are well known, and the subcutaneous use of insulin is also a controversy. So there are many areas which young people here can take up for research. Thank you very much for a patient hearing.
It was an excellent presentation, madam, and it really reminds of our undergraduate days when we used to listen to good teachers taking good classes. And if time permits, we will take 1 or 2 questions.
Euglycemic ketoacidosis is actually a lesser problem than diabetic ketoacidosis.
Physiologic solution of sodium chloride, it worsens the renal function, makes the acidosis worse. Now there is a new trend, these are called our balanced solution, and we are critical care nephrologists and also critical care physicians. Lot of data is coming out that we shouldn't use the sodium chloride because there are more than a dozen deleterious effects of chloride at that high dose. Normal serum chloride is anywhere from 96 to 106. When you have a patient with a serum chloride of more than 106 or reaching that limit, when you use the sodium chloride solution which has 150 millimoles of chloride, it may have a deleterious effect on the kidney, not only in worsening the acidosis. So people are now turning on to the balanced salt solution. A lot of institutions in ICU have now turned on to balanced salt solution.
Thank you, sir, for that comment. Actually, I am unaware of that concept and I really don't know. But I have not observed much of deterioration. We have been using this regimen for a long time and definitely it's a point to think over.